Hello.
Morning, everybody. Hi. And thank you for joining us as we come back from our brief summer break of, well, basically having a break. How are we doing, Andy?
Yeah, I'm good, thank you. Yeah, feeling relatively refreshed. We've had a break from podcasting and vlogging, but well, you've been putting out a lot of content. I've had a bit of a break from that, but still had plenty to do in the background, PCM-wise and practice-wise, but feeling a little bit refreshed. How about you, Gandhi?
Yeah.
Refreshed?
Refresh is probably the wrong word. I think, like you said, it's been a busy few weeks. So various presentations and stuff that we've been doing, including live stuff for the webinars. And actually, myself and Dr. Ed Pooley just finished off our remote consulting 5-day challenge that we've been doing for the past week. So we went live both 6:15 in the morning and 7:15 in the evening every day for the past 5 days, trying to help people remote consulting. And if people do want to catch up on all of that kind of content and stuff, feel free to just sign up to that link. You'll get all the details and the challenge and basically everything related to it. It was really fun, actually. A bit hectic, as you can imagine, going live twice a day on top of doing, like you say, normal general practice work and PCN work, and the fact that our practice had a few issues with people having to self-isolate as well. So it could have been better timed, I guess, but it was really good fun, really good content. Love the engagement, and yeah, definitely thinking that that's going to be something we could do again. Hopefully, when things are a little bit calmer, if that ever happens.
Maybe the two of us can do a challenge 1 week.
Yeah, well, social media is a good one, so I'm thinking that's going to be the next on the list, if I'm being honest. So watch this space.
Okay, I like that challenge because I need to really up my social media game because I've sort of become a little bit divorced and remote from social media. So I blame many of the ills of the world on social media at the moment. So I have a problematic relationship with it.
Yeah, well, that's the thing. Social media is both an amazing tool, and just like any tool, it can be used for good or for bad. And so it all comes down to how you use it, as ever.
Very true.
But yeah.
So, Gandhi, I know one of the things that has kept you very, very busy over the past few weeks is preparing for the Digital First Primary Care Conference that's coming up. So it's probably a good opportunity for you to just give us an update on how the preparations for that are coming along.
Definitely. So if people do want to sign up, the link's just there. It's going really well, actually. So we've got some amazing content planned for our viewers and stuff. So this is on the 30th of September. So it's a Wednesday, 10 till 3 o'clock. It may sound like a lot of time, but the cool thing is because it's a virtual conference, you can dip in and out, and you'll have guaranteed all the recordings from the sessions afterwards as well. So not to worry if you can't make all or part of it, because you'll get all the content afterwards. But the reason why it's looking so good, so we've got some amazing content. We're talking about digital first primary care, both with Dr. Minal Bakai, who's NHS England's lead for this particular topic, as well as various providers, including Accurix, primary care pathways, Ardens and IHO talking about how they can help practices. And even more amazingly, we've got NHSX coming to talk about the various different tech tips and support that you can now access through their routes. Interestingly, over the past week, I've been having chats with HEE, so Health Education England, and they're going to be helping us to have a roundtable about how education is changing in general practice and primary care, and particularly from a digital perspective, because also we've had lots of RAS, so changes both with the RCA and with appraisal, all that kind of stuff, but also not just education for GPs, but the wider primary care team as well. And then we're going to finish off, with somebody that you may have heard of, Dr. Nikki Kanani, talking about the future of general practice itself. I mean,
Yeah, they don't come much bigger and better than Nikki Kanani. She's an excellent online engager and presence for general practice. Yeah. That's fantastic.
I must admit, I did try and get somebody that potentially is even slightly bigger. So I did even contact Matt Hancock to see if he was interested. Unfortunately, he's busy that day, according to his office. But yeah, you never know. He may still Zoom bomb in. Well, we will see, I guess.
Well, you can only ask, can't you? I think this conference is really timely and really well placed for those GPs, practices, PCNs, CCGs, or even bigger organizations who are kind of taking a pause post-COVID and thinking about their next kind of digital strategy, moves. What products do they need to purchase? What do they need to put in place? Great place to look at the smorgasbord of sponsors and speakers, and also to chat with the other delegates and engage with everybody. So I think that'd be a really, really fantastic event. So I'd encourage everyone to check out the link. If it looks interesting to you, sign up. I would say sign up early, because the organizers of these conferences need to kind of know how many people to plan for on the day, and everyone seems to leave it really late to sign up for digital events, it seems. So sign up early.
And
Big help
try and,
for us.
yeah, and I guess just to try and prompt that, a couple of things to know. So the price will go up very soon. So from next Friday, the price is going up to the full ticket price. At the moment, it's still on the early bird price of £20. It is going to go up. So if you do want to join us at less money, please do so soon. Additionally, I did forget one little thing, and I say little. We are hopefully going to be unveiling the digital journey plan for primary care. So this is a collaborative effort between various tech interested people, including Redmore Health, who are leading the charge in terms of how this is going to work. But this is basically to help your practice, to help your network understand its own digital journey and how that can be enhanced, supported, and developed to be more effective, both for the practice, the networks, and most definitely for the patients as well. So yeah, if you have any interest with tech and general practice, I would say this is going to be an awesome engagement opportunity for you to see what's coming, what's here, and what you can do. So definitely looking forward to it. Just got to get there now.
So, Gandhi, what are we talking about this morning? So we're back. It's the update episode. We generally have a look at some topical things that have been in the news or that have been doing the rounds on discussion forums and groups and WhatsApp groups. So what's on the menu this morning?
So we're going for a triple header today. We've got 3 topics we wanted to go through. So number one, a massive discussion piece recently has been the fact that there's the recently released information by the BMA about how to account for appointments in general practice. So we wanted to kind of briefly discuss this because I think it's very topical in general practice, and obviously the accounting process is done kind of in the background, but what we determine an appointment to be has been something, I mean, we've talked about it before, haven't we, Andy? We talked about it earlier on in the summer. But I think, the fact it's come back and the fact that I think the discussion needs to be developed a little bit more. So that's the first thing. Second up, I mean, we're just about to start flu season. So how could we not have an episode that didn't have a little bit of a focus on flu? So we're going to talk about that. And thirdly, there's been some interesting news articles about companies expanding into various other areas of general practice / public care. So we're going to talk about a company that's been doing, got some recent news about that. But before we launch into that, we just wanted to offer our congratulations to our fellow eGPlearner and regular listener. So congratulations to Dr. Sonali Kinra, who has been elected to the National RCGP Council. Awesome opportunity, I think, and great news, I think. And the fact that she's a good friend of ours is even doubly so making us proud, isn't it, Andy?
Oh, absolutely. Yeah. Sonali is absolutely fantastic. She's a great connector, engager, networker, hard worker, vocal, tells it how it is. I think she'll do a fantastic job, actually. She'll be a great asset to the council. And if she's watching this morning, say hello to Sonali, although maybe she's had a night out celebrating last night and is recovering and recuperating this morning. Who knows? So shall we kick off then, Gandhi, and go with the first topic? So I think really so this is the topic that so NHS Digital will in the near future be able to will be working with clinical record management system providers, so the likes of System 1 and EMIS and the other providers out there, to extract data about the activity taking place within general practice, and this will be based upon appointments in the appointments ledger, essentially. And this is the first time that NHS Digital or the NHS will have direct access to this level of detail of activity going on in general practice. So it's really interesting, and it raises a lot of questions. What will they do with this information? What is the intention around obtaining this information? And also some really crucial questions about actually what is an appointment, and actually is everything that happens in general practice actually accounted for on the appointment ledger screen? So a lot of people
so that's kind of true, Andy. Admittedly, so that they have had this information before.
Have they? Oh, okay.
Yeah, I think the key problem has been actually that what constitutes as an appointment is not the same as what it was 10 years ago or even 5 years ago, because we know for a fact that in general practice we know that an appointment is not a single unit of definable care, really, because it could mean anything. An appointment could be a telephone contact, it could be a online contact, it could be a face-to-face contact. It doesn't define who that content necessarily is with, because there's no standardization. So I think this guidance is trying to standardize what is exactly is offered a little bit more effectively, particularly since now we're going to have PCNs offering care as well to try and capture that. So that information has been available, but it's just not been reliable. That's been the problem.
So perhaps sexing up the story a little bit there. But thanks for the correction there, Gandhi. Yeah, I mean, the interesting thing for me here was as you say, that they are defining what is, but also what is not an appointment, and that raises all sorts of questions about, well, if it's not counted, is it valued? You know, and what about the work that isn't counted there? So that's what's happening, and it's created quite a lot of buzz, particularly in some of the NHS digital sort of chat forums and so forth. Have we fully captured the buzz there? So what are the main talking points around this, do you think, Andy?
I think there's some question about how you account for certain types of appointments, so particularly things like supervision. The extra work the general practice does isn't captured, because the focus of this is trying to put the workload onto what's called the appointment book that many practices have. So in System 1, that's your rota. In EMIS, it's virtually the same thing effectively, but it's using that mechanism to try and capture the information, isn't it? I think the problem we've got is that it doesn't capture activity. It doesn't capture workload effectively, because it defines the appointment. And there is, I must admit, there is good guidance generally in terms of what that includes. So it does, try to break it down into patient-facing stuff, planned care, clinical admin. There is elements of that, but certain aspects don't seem to have been captured very well. So clinical supervision doesn't seem to be captured greatly. But the key thing is it doesn't actually end up showing a marker of activity. And I think that's where a lot of the frustrations in general practice seem to come from, in the fact that activity is what general practice would like to be captured, because then we can actually show how, to be honest, cost effective general practice is. I think many people massively underestimate the impact and the efficiency and the deliverability of general practice. And this is an opportunity potentially to show that. But if it's just counting appointments, my personal worry is it's just going to be a statistic for the government to say that we've increased appointments, and not actually value the workload that goes into delivering all that elements of care. I mean, we know over the past couple of months or so, many people keep saying general practice is shut. Let's be absolutely clear, general practice is never shut. We've been open throughout the entire pandemic and working and hard so, and yet that message is still being perpetuated over and over again. My worry is that some of this is going to still continue to drive that message in the wrong way, I guess. But
yeah,
you need to stop me.
It's always easy to not easy, but it's often we drift into the mode of not complaining, but there's so much frustration out there, isn't there? But sometimes we need to make sure that we're focusing on more positive aspects, I guess. So it is interesting. So I suppose the interesting thing for me is over the years that I've been a GP, and that's been about 10 years now, I think the number of appointments that I do a day, the number of contacts has stayed the same. But I feel that I work a lot harder now than I used to, even 10 years ago. And those GPs that have been in the game longer than I have will say, 20 years ago, you could go home and walk your dog at lunchtime. You could do all sorts of things. It was a much slower pace, but they were still doing, 15 or more appointments in the morning and the afternoon, and that's what we do now. I think what's changed is that in individual appointments, we're often dealing with more problems. And a concern will be that actually just counting the number of appointments doesn't account for the increased number of issues and complexity of issues within the appointments. And that is increased work. And the other thing as well is the area of my work that I think has really increased is paperwork. I think a lot of people would say that. There is a lot higher volume and traffic of information about patients moving between primary and secondary care and back and forth and to other parts of the care and social care system that people in general practice have to read, action, do things about, reply to, and we do more blood tests as well. And those things are specifically excluded from the definition of an appointment. It's I would argue, an episode of care relating to a specific patient, but it's excluded from the definition of appointments. And actually, that's where all of the workload increase has been. So I think for me, the big danger is that you miss that increase in workload that's happened over time, that may continue to happen over time, and then it's not counted. And when things aren't counted, often they're not valued by the system. And if they're not counted, they're not aware of it. How can that be appropriately funded so that we have the funding to actually do it and do a good job? So, so this is why I have worries about it, and why I think everyone on the forums has worries about this issue.
I'd probably counter that and say that actually our contacts have gone up. Like you said, maybe the number of people we potentially see face-to-face has balanced out, and particularly post-COVID. Obviously, we are seeing a lot less people face-to-face because we now have additional tools and engagement with tools to facilitate other ways of working. So remote working in particular has massively spiked. We know that 80% of practices are now using telephone consultations. I think something like a similar number now have access to video consultations, where if you went back last year, only about 8% of practices had access to video consultations. So the way that we see patients has changed, but the number of contacts we have with patients that has actually increased significantly. When I started at the practice in Nottingham in Wellspring, which was 8.5 years ago, my average day would be, like you said, about 15 patients in the morning, about 15 patients in the afternoon, and a few, pieces of paperwork in between, which meant that we had really good time to try and support the rest of the team, to do a lot of the other stuff that was going on, and it was not too bad. Nowadays, the 15 contacts is a drop in the water, to be honest. Some mornings I will have over 30 to 40 patient contacts just in one session. In between that, there's the letters, there's the paperwork, there's the additional meetings and bureaucracy that is now being added on to absolutely everything we're doing. Squidging, additional Zoom meetings and PCN stuff in between all of that. Okay, fair enough. That's an extra hat I've got that is, not as relevant to some people. But that intensity and like you said, the complexity of the workload. That's the other part I think people forget. What people are attending with now is infinitely more complex, because we're dealing with so many more health issues than we used to. We barely used to deal with heart failure, for example, as an example, when I started in Nottingham, and I see probably about 4 or 5 cases where I'm the sole management of heart failure for that patient, because they're not eligible for secondary care cover anymore because of the changed instruction services that we have. It's done this. And I think the frustration for many within the profession is that the appointment stuff is a good start at standardizing what is being reported, but it in no way really captures the workload. And I think that's what many people want it to show. And maybe it's with aligning our views of what it's meant to do and not meant to do. But what we want is to show the workload, because then I think people will potentially value what general practice can do so much more effectively.
Yeah, absolutely. And I think there's an opportunity here potentially for NHS Digital to work with the clinical records management system providers to maybe go a step further, because there is actually a lot of data about that additional work. The numbers of letters that are processed and by whom is recorded with digital systems. The numbers of blood results that are processed are recorded. The number of tasks, that's where messages fly back and forth between people, and people make decisions and support one another. The volume of those is there as well. That also could be quantified and extracted to give a better representation of the work that's taking place. And I think actually that would probably turn this from being something which is controversial into something that might be much more welcomed, because it would be considered much more accurate in terms of representing the amount of work that takes place. So I think there's potentially an opportunity there to go a little bit further. Gandhi, I've got a question for you. This is more generally about GP workload, but and it's a bit of a loaded question. Do you think the profession deludes itself a little bit in the way it talks about how much work we do and how much we expect ourselves and our colleagues to do. What's led me to this is, when you're recruiting locum GPs or salary GPs, we talk about a session, don't we? And often we say, a session is 4 hours long, 3.5 hours clinical contact and half an hour admin. And there's 2 of those a day. And that's how we make up our working week. And everybody talks in these terms and in this language, like that's what it is. But it often isn't. Are we deluding ourselves in a profession in terms of talking in that way? Do you think, Gandhi? What do you think about that?
I think it's both sides of the coin, isn't it? Unfortunately, so one of the things we know is that there is the viewpoint that many have that you just get on and do the work, and part of this I think comes down to the independent contractor status that general practice is commissioned effectively to offer care under the capitation model. So we get paid, I can't remember the exact number, but approximately £150 per patient per year to deliver primary care to patients, and we provide everything within that envelope. So for less than most people would probably pay for their mobile phone, you get complete and utter primary care healthcare access. And the interesting thing with that is, like you said, it's what does that care mean? Because if you've got demand doing this, but your capacity is only here, how are you going to deal with that shortfall? Well, the answer is that unfortunately falls to the partners, and therefore they're doing a lot of potentially additional work when they shouldn't be. I mean, you and I are both partners. I'm meant to be 6.5 sessions. I think you're 6 sessions, if I remember rightly.
7, yeah.
7, okay. So like you said, a typical session is 4 hours and 10 minutes by indemnity standards. For example, you should be doing just under 29 hours a week in primary care. Can you honestly tell me the last time you did 29 hours?
Oh, never. Yeah. It's crazy, isn't it? But I just feel maybe we would all benefit from being more honest. But the trouble is, if I was honest with people, when we go out to recruitment for posts and things, I mean, everyone expects there to be more work than 2 4 hours a day. But if the first people that are actually honest about it are going to look very unattractive to new GPs.
Well, this raises an interesting perspective that's coming through, and I'm going to talk about it with my PCN hat on. Obviously, we're now trying to hire PCN staff, and we have an envelope of amount that we can do that within, because that's what we are reimbursed to offer. So NHS England are now reimbursing 100% of the roles at a ceiling level. So I believe, for example, for some of the more well-trained roles, like the pharmacists and the physiotherapies and stuff, it's about £56,000 is the maximum reimbursement you can claim for from NHS England. Anything above that you offer to the individual comes out of the PCN pocket. Unfortunately, the level of banding that you get for that doesn't necessarily equate to the roles, and I know many places are having to put their hands in their pockets and pay extra, because it's the only way to secure the people who are willing to do the full-time work for that amount of money. And that's because I think the growing workforce, both from PCN staff, but also within general practice, like you say, salaried and locum doctors, value work-life balance more than financial remuneration, and are very much sticking to rule a lot more effectively than I think many of us used to do. Because like you said, there's that acceptance we end up doing more work than we should. But is that right? Should we be willing to take on additional work and do it for free, effectively, because that's what we're doing, risk burnout, risk wearing ourselves down, without the recognition of the amount of work that we actually can and often do? And I think that's where possibly some of the undertones of this appointment stuff has come from. Like I said, people wanted to actually show activity and workload, not just an arbitrary number of appointments that can be used as a statistic. And I think that's going to be the interesting challenge. And that's also one, like you said, one of the challenges within the profession itself. People accept that, people don't want to do what we're doing. Well, to be honest, would we still want to do what we're doing right now if we came to this afresh? Would we accept that? And why are we accepting that?
They're very good questions, Gandhi. Very deep questions that I don't necessarily know the answer to. There's a bit of the boiling frog kind of principle that plays in there a lot of the time.
It also feeds into this interesting discussion that keeps coming up that the general practice should become a salaried profession. Yeah. I mean, we hear that quite often, don't we? And it's often bandied around often by people that don't work in general practice, which is one of the interesting things. It's normally secondary care consultants or media people that say, just pay them a set amount and, don't let them be partners, don't let them be independent contractors. Let's be absolutely clear. If general practice were to rule, the NHS would be financially crippled because we absorb so much more work than the amount of the finance we are paid. And partners in particular in practice take on so much additional work that is not funded that if we were to work to rule, either we wouldn't be working or the bill would double at least. And
I agree. Yeah. So I agree with you. So I agree completely with that. The puzzling thing for me is, and you've hinted at it, the people who say, oh, maybe general practice should become a salaried profession. It is maybe hospital consultants, administrators, people from outside the industry. You hear it much less from GP partners, the sort of people like us who are actually sitting here complaining about the situation. We tend not to say that. So Gandhi, would you swap? You could take your current pay and be salaried, and go home at the end of the day. You'd stay a little bit for patient safety and stuff, but you'd do a lot less work. Now, would you take that?
Yeah,
you would.
I would. If, and this is the big if, and this is the part that will never happen. If it wasn't that something came back to me because I've done what I've been paid to do, rather than, and that's the worry that many in general practice have right now, that when something goes wrong because you haven't done, okay, this may come out wrong. We obviously have a duty of care, we have candor of care that comes into play, like you said, and there's an element of patient safety. But the perception of what that is for many people, particularly those outside of general practice, is completely different to the funding that allows us to offer primary care. So, patient wants to be seen, they have to have some element of care. Not that responsibility also goes back to, I guess, the patient or to the system in terms of the fact there isn't the capacity to deliver that. And I think this is where potentially the argument about, should primary care be completely free to access, unlimited, without restriction, comes into play. Because right or wrongly, that's what makes people think more appropriately should they use a service. And we saw that, for example, with plastic bags. Plastic bags, people would waste them significantly. All it took was a 5p charge, and the wastage of plastic bags significantly improved.
Interesting. Yeah. So interesting response there, Gandhi, because often people say, no, I like the level of, control I have over, what happens to my practice, my job. I feel that allows me, I like adding value by making those organizational decisions. That's the sort of thing that you normally hear. So it's interesting to hear. I'd take that. And I think really it's about looking perhaps at our consultant colleagues, actually, because they still have lots of respect, control over what happens clinically within the environments they work, but they are salaried. And from my experience, they do additional work and they add a lot of additional value. It seems to be more funded and recognized, and they get their PA slots in which to do a lot of that work if they're doing it. So maybe we should be moving towards a system like that. I think the fear I have is that it's all completely unaffordable and it won't work.
Yeah. I guess my viewpoint on that is the reason why a lot of that is there is because the access to secondary care is completely restricted in comparison to what it is in primary care. I think if you were an inpatient under a clinic and you had unrestricted access to that clinic, that perception would be very different. But patients don't. If they want to speak to a consultant, they either have to go through a service that then often directs them back to their GP for common things. Not all. I'll be absolutely clear. Many of our secondary care colleagues are amazing at what they do, and several clinics are amazing at offering that personalised care to patients. But majority Yeah. Oh, you want to be seen sooner? Go speak to your GP and get a letter to have that happen. Why is completely beyond me. But I think it's the access. It's the fact that because they are harder to access as a result, there is a greater level of respect from a patient perception point of view. And I see that with I'm not talking about as a GP. I talk about that with my own family and stuff. You know, the viewpoint is very different from that perspective.
Yeah, but I suppose if you're no longer a partner and you're just a salaried employee, that's you no longer hold responsibility for that problem. It's the people who are organising the service who then hold, responsibility for that problem. Although you might still hold some moral responsibility for, a situation in a system that's not functioning as well as the previous system, I suppose, and that would hold a lot of people back. But yeah, interesting question, and you surprised me a little bit there with your answer, which is it's always good to be surprised on a Saturday morning.
Yeah, no, don't get me wrong. I love I love the organisational aspects of general practice. Always have done, and in that respect, I would never not want to be a partner. Like you say, the ability to have an impact on changes and that kind of stuff. But I guess the part I struggle with is the fact that effectively we are asked to provide care, which we do really, really well and effectively. But then the viewpoint, and I think recently, in particular over the past few weeks, the thing that's increasingly frustrating me is that the commentary from other areas about the fact that general practice is shut, the fact that general practice doesn't do enough. I think increasingly, I think many people are seeing that that's a frustration that needs to be addressed both publicly and nationally, because we are struggling to counter that. And if you want to look at it from one perspective, you go back a couple of months ago, people were clapping for everyone across the NHS, and now all we're getting is complaints and myriad of other issues, which actually general practice has very little control over, and that's a hard place to be and live with.
Very true. So what are we doing? What are we going to do about this issue of the appointment? So I guess you're going to start putting everything that can possibly go on the appointment ledger onto the appointment ledger, even if historically you wouldn't have done. Yeah, I think all practices are who are aware of this are looking to do that. So, and it seems the rule of thumb is really anything that involves a direct interaction between a clinical member of staff and the patient can count as an appointment. That's sort of my reading, and it's really those things which are purely administrative. That big wide definition, if actually that's including filing blood results and reading letters and actioning letters, I think that's actually clinical, I think, but not including those and not including contacts between, say, the practice manager and patients or receptionists and patients. So, but everything else, put it on the ledger and then lobby for, as the next step, NHS England to start looking at that kind of task and results and letters workload, which will give them a better impression of what's happening in general practice. I guess that's all we can do, I suppose.
I think it's important to recognise the introduction of digital online access. So Mamta's commented on the group about, doesn't having digital access make this access even more free for all at any time? Well, yes, it does. It means that access can be delivered at any point. But I think one of the key things that practice now will have to do is capture that information. Not that you have a single block of appointments that says online consultations. You have a system whereby you're allocating each individual contact with that patient through online methods an appointment. Because let's be clear, although it may not be a face-to-face appointment, and that is different, it is still a clinical encounter with the patient that involves you accessing the patient notes and providing care to that person. And then giving them clinical information or advice or signposting or treatment. And that is, by definition, a clinical encounter.
So it would count. I think Mamta's also driving at this issue of there being so much free access to general practice compared to other areas of the healthcare system, and do online appointments make that even worse or better for the patient, but increase the demands on the profession? The answer is yes, isn't it?
Yeah. And I think this is one of the general fears that many people are now seeing with the switch on of total triage and digital access. Interesting, that's what we're going to be covering at the Digital Primary Care Conference. So slight little segue into that. Yeah,
So
and I know specifically I've asked Min Al-Bukai to address this issue, hopefully to some degree, because I know it's a growing concern within general practice of how on earth can we deal with what's seeming like an increasing tsunami of demand. It's not just because of digital access, let's be clear. We are seeing the post-COVID tsunami that's coming through. You know, all those health issues that many people put on hold for a while. We're seeing the increase in mental health burden from COVID building and growing, and you know, it's unfortunately coming up possibly a really bad time with flu and everything else, but hey, it's coming, so we need to deal with it.
So next story. Let's
it's a great segue to flu, isn't it?
So is this a positive story? Maybe it is. So Pulse a few weeks ago, how GPs are preparing themselves for this year's mammoth flu program. So there's been some expansion to those people that were going to be aiming to immunize this year against flu. So my understanding is that we've added in shielding patients and also over 50s to the existing groups. Am I right there? Anyone I've missed out there, Gandhi?
So are those living in the household of shielded patients as well?
Yeah.
Important not to forget those. They've been included. And like you say, the expansion of the age bracket from what was it 60 or 65 plus to 50 to 50 plus effectively.
It's 50 plus. I think 65 is before. It's funny how you forget these more nursing based kind of things that go on. So, but many more patients, and also we've all still got somewhat depending on the local guidelines in the area, we've all still got infection control measures that we need to respect in this sort of COVID period, in terms of social distancing within practices, limiting the amount of space, and I think in some areas probably having separate entrances and exits, well, particularly when you're dealing with high volumes of patients. So I know we've found some of these things a bit of a challenge at our practice, and we're having to do things differently. I suppose the other thing to say is there's also been some talk about how technology can help speed up data entry and interactions through use of barcode scanners and so forth. So Gandhi, what are you guys doing differently about flu in your practice this year?
Yeah, I think there's various challenges, like you said, that comes with it. So we've obviously got the expansion in the number of people that are now eligible for the flu jab. We've also got, like you said, the added complications of social distancing, trying to deliver it, because many people probably remember our previous years, you'd have a waiting room full of people waiting to have their flu jab. And we're not allowed to do that. We can't do that because that's going to lead to a spike in COVID even more so than what we're currently experiencing. So, trying to deliver social distancing on top of that. And then, like you said, the IPC, so the infection control requirements are quite limiting in some capacities for some places. So, for example, you have to have a separate entrance in and out. Well, many people would say, well, that's surely easy to do. Actually, it's not. There are some practices that have never been designed to have that kind of mechanism. Yes, they have a second entrance, but that may be, for example, the fire exit, which then goes through the administrative area of the practice, and therefore patients that are walking through, how does that work from an infection control perspective? Flow of patients. Originally, there was obviously the infection control guidelines that stated that nurses will have to change mask, gown, and gloves in between every single patient that they're injecting. That guidance has now changed to be a lot less requirements on PPE, but still fairly, it takes longer basically to deliver an injection. So we've got an increased number of injections, increased time it takes to deliver an immunization. And then on top of that, we've got obviously the restrictions in terms of how you can flow people through the system. Now, you're right, there are potentially ways that tech can help. One of the biggest talked about ones is using barcodes to help do a lot of the administrative components of trying to organize patients, and obviously increase use of things like text messaging and online consultations to send messages to patients to say this is how to come in, rather than what we used to do was to send letters, which is the most ridiculous way, I think, of trying to organize one of these clinics personally. But however, it's still a requirement. You still have to send them a letter. To invite them to the clinic to make sure you get the funding in order to continue to do this. But I think the real limitation that we're going to see, which no one seems to be really keen on talking about, is that practices had to order their vaccinations back in January for the amount of people that they needed to vaccinate. So, majority of practices did so based on their annual amounts that they would have to do. We're now being told that we have to deliver a lot more injections to a lot more people and a lot higher ratios in order to make sure we get the funding to make sure we can keep doing this work, but no clarity in where these extra vaccinations are coming from. We still don't have a clue if we're getting any more vaccines than we got last year.
They have increased the funding for some of the categories, haven't they, Gandhi? Which I think is helpful. Some of the higher risk categories, they have increased the funding, which I think is a helpful move. That's really good. Just thinking about kind of practical solutions. So I know in my practice, we're doing things very differently this year. Actually, we're fortunate enough to be in one of these sort of larger, I say purpose-built buildings, but it's not really built with pandemics in mind. I must admit, the area of the building that we actually inhabit only has one way in and one way out. And if you need to use a fire exit, then you've got to sort of go across a grassy area that's actually a floodplain, and there's a locked fence that you have to get through to get to the fire assembly point in the car park. So you can't really, and it's down quite steep steps, so it's not really suitable for flowing patients through at all. So we're having to work with our landlords. On the ground floor, there's like a large library sort of open plan space, so we're going to be working in that space at least on Saturday morning flu clinics. A lot more space to allow large numbers of people, or large-ish numbers of people, to queue in a socially distanced manner. We're being tighter in terms of the time slots that we're telling people to arrive, book in their flu jab, and telling people just to arrive at, just before their time. Don't come early. That's just going to spoil our crowd management. And we've been looking at that kind of process of what people do when they come. We're not using barcodes, but we've been looking at making the process of getting the administration done and getting the flu jab in the arm a lot more slicker for our nursing staff. So that's interesting. So we are doing things really differently, and we'll see how it pans out for us. And we're having to put more clinics, obviously, than we normally would, and prioritizing those at greatest risk first, as per the guidance. And then I think it says, depending on available vaccines, do the over 50s later on. So we'll see how much vaccine is left.
And I think that probably speaks to the other area that really does need some extra support and consideration of how we deal with it. So, increasingly, I'm hearing more and more patients telling me about misinformation about the vaccines. So, I've had one patient tell me that the flu vaccine contains COVID. So that's why they don't want to have it. That's the fake news that's going out around at this point. And that's a really challenging thing sometimes to deal with, because one of the things we know, that COVID does seem to affect particular minorities significantly more than others. And actually, they're the ones that we are trying to prioritize to try and safeguard them from the general flu, because we know that they are therefore more likely to suffer more significantly when they get COVID, or if they were to get COVID as a result. So that needs to be tackled. I think many practices are concerned about the 50 to 65 age category group insisting that they get vaccinated first, because there isn't a great deal of public information about the fact that that is not the case, that they will be vaccinated after we've done the higher risk categories. And that's the clear instruction we have had from NHS England and Public Health, that that's what has to happen. And unfortunately, the fact that information going out doesn't seem to be very, very public is, I think we're going to have lots of complaints and challenges at times in clinics with people turning up for that. And then there's the third issue, which, is inevitably going to happen. At some point, we're going to be asked to do a mass vaccination of COVID patients, when the vaccine for COVID does come about. And how on earth are we going to do that in general practice? Because I don't think we can. We just do not have the workforce and the state's opportunities to vaccinate the entire country for a vaccine. On top of, again, there's the challenge that you can't do it at the same time as the flu vax. You have to do it 4 weeks apart. There's that added thing. So I think Boris mentioned that the COVID vaccine will not come till next year. how are we meant to do that? You know, I don't know. It's a challenge, and I think misinformation really needs to be tackled quite acutely, because we are, like I said, about to start the flu vaccine campaigns. And I still have patients worried about how it's going to affect them. COVID, misinformation about COVID with the vaccines. Yeah, I remember having one parent who was having his child have their normal health immunization, baby IMS, and they're like, "You better make sure there's no COVID in that immunization." I'm like, "Oh, well, we don't even have an immunization for COVID." No, I don't care. I don't want it if it's a COVID vaccine. And I'm like, well, hold on a second. That's not even what we're here for. That we're here to offer your normal baby, and that took time to explain. And if that happens in the middle of a flu clinic, the knock-on effect is going to be significant, and risk, and all the other kind of things. And it's just,
Again, where are these people getting their misinformation from?
yeah.
Where's it come from? Because you may not have asked them, but there's always that temptation to say, so you're telling me this, but so where did you hear that from?
Yeah.
Know?
I think it's partly, social media has a place to play with this. We've talked previously about some of the social media companies need to potentially do a lot more in terms of helping understand the misinformation around public health. And to be fair, they have done a lot better with COVID than they have done with previous issues. I know when Ebola and stuff came out, there was virtually no control by social media companies. Whereas when COVID came out, a lot of them did start putting. We talked about in previous episodes how they were prioritizing official sources of information in their feeds and that kind of stuff. But it is just misinformation spreading. It's often a family member has said this, or an official on TV has said this, and just need to remember that what people say has a massive implication on what people do as a result of that. And spreading fake or false information should never happen. And if it does, the implications of it are far-reaching, and it's not often captured by people. I'm ranting again, Andy. You need to stop me doing that.
I will. Yeah, I'll like wave at you or something. So, yeah, Gandhi, we need to do an episode on fake news, on fake.
Ooh, I like the idea of that. Yeah,
because it's damaging to health. It's a real issue, and it's technologically related. So we need to, in a few weeks, we need to do an episode on that. So shall we move on to the final story that we picked out? So I think I've still got the screen share active. So this is a story. It's a first. So a CCG up in the north of England, in Tyneside, has entered into agreement with LIVI, which is a company that I think we've talked about a few times on the show before. It's a number of things, but it does video GP consultations amongst a number of other functions. And they signed up to allow all 220,000 of the patients covered by their 25 GP practices to have access to video consultations provided by this private provider at weekends and evenings and during the week, which I think is a huge thing. It's a first. The article says it's a first. I'm not aware that something similar has happened elsewhere. So I think it is something that is worth talking about. The article doesn't say how it's funded, so I've reached the assumption that it's probably extended access funding, because that that best maps onto the times that these appointments are available. But they might have used a funding source, and of course, there's all sorts of implications for the direction that this takes the CCG, the impact that it has on the other organisations like their primary care networks or local federations or practices that don't get the ability to provide extended access or whatever else the funding might have paid for. And I suppose there's a question still. We're a big fan of video appointments, and they're a useful tool. They're always going to be the right way for those patients to access care at that time, and what happens if they need to convert to a face-to-face appointment? Do they just go to their GP practice anyway? What's the risk attitude of the LIVI professionals, and do they respect the resource that they use when they convert to face-to-face? I'm the one ranting now, Gandhi. All sorts of things raised by this. What do you make of this news, or just the general principles at play?
Yeah, I mean, to be clear, we don't have the full information because obviously we're going off what's reported in the Pulse magazine. I think it's an interesting use of opportunity, isn't it? Because if it is for things like extended access or potentially extended hours, you're then speaking more ideally to a population, which is what those services are designed to provide, which is access to those that typically wouldn't access normal primary care, i.e. those that are typically working, because that's when most of general practice is open. And theoretically, that's a population that should be more inclined to use video-based consultation because they are generally more tech-enabled and stuff. Clearly, some generalizations in that comment. But I think using it as a mechanism is quite interesting. The fact that it's covering an entire CCG, so 229,000 patients, offers the opportunity for working at scale and the budgets and that kind of stuff, and that's where it becomes quite useful. But you're right, there's definitely some logistical issues that I think would hopefully have had good consideration of how that worked. I think the acceptance of video consultations has significantly increased, particularly post-COVID. So therefore, doing it that way, I think, is more effective. I think also clinician acceptance of video consultations has increased. It's by no means still as good as I think it could be, although I appreciate I'm a big fan of video consultations. But it's also remembering that there are definitely situations and opportunities where video consultations are not the right way to deliver care, and how is that therefore being supported, covered, and financed, and all the other kind of stuff. It will be an interesting thing. I've generally heard quite positive things about LIVI, which is nice to know. I think there are other areas where similar stuff has been done. I remember, I think it was Push Doctor were commissioned to offer extended access hours appointments for somewhere in Hull, if I remember rightly. So I don't know if this is the first, but maybe the first in this significant scale. Or
maybe it's the numbers and that it's the entirety of a CCG rather than in partnership with a super practice, for example. That's where Push have perhaps been at play before. I mean, also actually, I have heard positive things about LIVI as well. So one of the practices in our primary care network, St Albans and Namala practice, are part of a larger practice group. And they have been using LIVI for some time to make video consultations available for their patients. And the staff that I talked to at that practice, I haven't spoken to patients about it, think that it is a positive service. So we shouldn't necessarily be negative about this. I just think it's a big thing. And as you say, the hope is that they've ironed out some of the issues and really given them good consideration and thought. Putting it in place, or at least that they're willing to pivot and adapt if issues arise. So interesting story. And I'm going to lead into the final story just because it's referenced within this story actually, and is another LIVI-based story. So Boots are to partner with LIVI to make video GP consultations available within some of their stores, which I think is really interesting. So they've got a representation there of an iPad on a stick. I don't know quite whether that's what it will look like in reality, but they're partnering with them. So this will be a private consultation, and this will cost £25. The article advises us, which I think is similar to the sorts of numbers that people would pay for a similar consultation on their phone, Gandhi. You're probably closer to the pricing models of these companies. I've heard generally 25, sort of £30 sort of mark, but obviously you're having to do this within a Boots store. I suppose the advantage of Boots is that you might pick up a packet of paracetamol while you're there, or some other remedy that may be suggested by the GP or you otherwise need. It's great to drive footfall into a bricks and mortar retail outlet. So that's one imagines one of the attractions for Boots, and there's synergy with a lot of the products that they sell. And of course, I'm sure LIVI are very keen to expand their service. So I think it's really interesting. What do you think, Andy? And any downsides, I suppose? Access to GP practice paid for in a convenient way. Surely that'll take some.
I think the key point that this will come down to is what happens as the outcome of the consultation. I think that's going to be my main question. So if a patient uses the service, and if it is a private service and they're then determined to need some further follow-up, is that going to be, okay, you need to go speak to your GP because we can't arrange that follow-up in that way. If they need things like investigation, like blood tests, more detailed tests, or other kind of treatments ongoing. And more importantly, how does that information get back to the practice as well? Because if it's not linked with the records, which I suspect they're probably not, because even we struggle to do that with services that we are working with, let alone services we're not directly working with.
Yeah, then how is that information to the records?
Yeah, so it's access to the record, because this won't be NHS care, because they won't have access to the records.
There will be access in the Newcastle story, the Tyneside story before.
Yes, the first story they will. The Boots one, they won't have access to, that kind of thing. So how is that going to work? I mean, is that just going to be an instruction to the GP? In which case, I think a lot of practices will be thinking, why? It's that false expectation that sometimes gets set up by providing services or advice to patients that you're not regularly involved with, because you're not aware of the local implications. And I'll hold my hands up on this one. So I think last week I made a tweet about, after having a really bad day in general practice, a pet peeve of mine, which was A&E ED doctors basically directing the type of care that I should be offering to patients. So I had, unfortunately, a run of 4 or 5 of these. And I'll hold my hands up as well. I probably shouldn't have tweeted about it. I was annoyed at the time. So some social media guidance here, guys. But it generated a lot of discussion. And right or wrongly, I think, it's that instruction or direction of care that should happen. And it's very hard to make that direction when you don't know what the other side of the place can do. So, for example, general practice can offer amazing breadth and depth of the services we can offer, and actually we also have a lot of restrictions in terms of what we can do as well. So it's not as simple as just referring a patient onto the secondary care. Often there are a lot of things we have to do before we can even consider doing that, because of the current situation, because of the current guidance, and also what's appropriate care. And having somebody say, just do this, partly I think there's a patient element of communication there, but also I think there's understanding that that's not how things work. So go get an MRI for your back pain, go get a referral to secondary care for this. And my concern, I guess, with this is that it's quite easy for a private service to do, because we've seen that happen numerous times from various private providers. Go get XYZ blood test done and an X-ray and this, and go to your GP and get it done. And actually that may not be what's appropriate or sensible for that patient. And it may also not be what's even possible because of the information that's been shared.
So yeah, interesting. Although I'm interested to see what happens with this, because it's another example of putting a price on a GP appointment, which I think is no bad thing really, because the more people understand that actually a face-to-face GP appointment in a practice has value, and that value is probably in excess of £25 a pop. I think that's a positive thing. And what I would be really interested to see, and this information may never come out, but the outcome statistics from these appointments, because if actually they conclude a lot of episodes of care successfully that might have otherwise gone to GP practices, and patients are happy and they're happy to pay for that, accessing that care in that way, it may take a little bit of pressure off GP practices, so they can spend more time with complex people who don't want to access and pay for care in this way, and it may be a positive thing. So I'd be very interested to see if we ever see any of that sort of data. So let's see. I think I'm gonna remain neutral on this topic myself. So I think that's the end of the stories that we had this morning. So hopefully that's been interesting for people to listen to us rant and rave about it. Hopefully we've not been too negative about things, and I think there are some positives in some of the stories that we've covered this morning. So anything to say before we close, Gandhi?
No, I think it's so we've had a slightly longer episode than normal. I guess it's partly because we've had a bit of a break as well. So myself and Andy have not had the chance to speak with you all for a while. But thank you for joining us. Definitely make sure if you're interested, join up for our, like I said, digital primary care conference. We'll be talking about some of these issues that came up in considerable more detail with the people that are in the know as well. So if you want tickets to that, just sign up down there. Definitely make sure you subscribe so you can get all of our content continually and first, and all the other kind of stuff. And thank you for everyone that has joined us on the stream and commenting live. Feel free to continue to do so. Feel free to mention down below any other comments or queries you've got, because we love to talk about this stuff. We're back again in 2 weeks' time. We've got more stuff coming for you as planned in the near future, so make sure you stay tuned. As I said, definitely subscribe. And I guess, as always, eGPlearner is here to help save you and your patients time by taking out in your primary care and learning. And we will catch you in the next episode.
Enjoy your weekend, guys. Goodbye.